I think that these drugs are miracles. Like someone was saying the other day, oh, well, you're taking this drug. I said, this drug has been a miracle for me. This drug has changed my entire life, my entire well-being, my mental health, my physical health, everything. I'm not a religious person. I'm much more of a spiritual person, but I pray to the Manjaro gods every day.
This is Fat Science, a podcast dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better. This podcast is for informational purposes only and is not intended to replace professional medical advice.
I'm Dr. Emily Cooper. I've been treating patients with metabolic issues for over 25 years. I'm on a mission to raise awareness about metabolic dysfunction and why diets don't work.
Hi, I'm Andrea Taylor. I've been fat, very fat, chubby, morbidly obese, and done almost every diet ever invented. They all worked until they didn't. I've known Dr. Cooper forever, but when I became her patient and we learned metabolism was the real problem, wow, everything changed, and I've never been healthier.
And I'm Mark Wright. It's time for Fat Science.
Wait, does this podcast make me look fat?
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. It's great to see you both.
Hello.
Hi.
All right, on the show this week, what is the best GLP-1 drug for me?
Rah, rah, rah.
Here we go. Gosh, I don't think I've heard more buzz, more excitement about any class of drugs, Dr. Cooper, than this GLP-1. So, Dr. Cooper, let's first of all make some definitions. What is a GLP-1 drug? And why are they so wildly popular right now?
This group of meds, they're called glucagon-like peptides, which mimic our own body's hormone by that name. And so they have the same function as our own body's GLP-1 hormone. And the GLP-1 hormone's made in our GI tract, typically in response to food intake. It increases in our bloodstream and also through our nervous system from the vagus nerve, which goes from our GI tract and sends signals to our brain about our food intake, basically. So the GLP-1, once it gets into the brain, that hormone helps reassure our brain that we have adequate amount of food, and it helps our brain see the food that we're eating in terms of like the nutritional content of it. And it gives a green light to our metabolic function to burn fuel and to regulate our body weight in more of a normal weight range and to keep our appetite more balanced, to reduce our hunger signals and increase our satiety signals once it starts elevating.
Isn't that amazing? Because I think the misperception that we have of the human body is that we're like a car. And when we eat, it's like putting gas in the tank. In a car, the gas is burned the same way every time. None of it's stored. All of the energy goes to moving the car or powering the AC or the radio or whatever. But it's all consumed. It's all burned up. There's nothing left over. But the human body is absolutely unlike that in that some of the fuel can be stored. Some of it can be burned or a combination of the both. And it's such a tricky system. This metabolic loop that we've talked about for so many episodes, Dr. Cooper, is this amazingly complex feedback loop of hormones that are constantly communicating with our brain to let our brain know the status of our fuel, of our health, of our body, right?
And then that fat that gets left behind on my tushy.
Well, and I always feel for people that have a lot of metabolic dysfunction where their brain can't perceive the accurate picture of maybe their food intake or even their body weight.
Right.
So those people are made to really not have access to that fuel availability to give them energy. And instead they have to carry around the fat stores all the time because they're not allowed to tap into that, because that's felt to be, a high commodity by the brain, because the brain is sensing that we're in a fuel shortage. So we have to hold on to that. And so that's just a place of being tired, carrying around that extra weight, and maybe not having normal satiety cues. That's a common feature of metabolic dysfunction. and having a more sluggish metabolic system.
Like when I first came to you, we did, I forget what the blood test was, but it was something. And my blood test reading said to you that my body thought that I weighed about like 95 pounds and was starving. Yet in reality, I weighed 340 pounds. I was having fatty liver. I had all kinds of health problems. And my brain was so confused from all the dieting and all the crazy things that I had done to lose weight, lost 100 pounds, gained 120, gained, all those kind of crazy fad diets, that my brain was so confused about what I had done to it that it was storing all the fat and holding on and wouldn't lose the weight. Like I couldn't lose any weight.
Absolutely. And we could see that through the blood testing. It was really the leptin level. Your leptin level was, with leptin, when we're analyzing it, there's a formula that we use that you plug in the BMI. Basically, BMI we know is flawed, but we use
Right.
BMI in this formula.
Right.
So a person who weighs this and is about that tall, their body, female, their body should emit a certain amount of leptin, their body fat. And so then based on this formula, your body fat was emitting the amount of leptin that someone who weighed like 95 pounds would emit. And so
So
that's
the
the
brain didn't
signal.
see it.
Yes, that's the
Yeah,
signal that the
Isn't
brain
that
had.
crazy?
that's crazy. And isn't it funny? I mean, when you look at a lot of health conditions, we are sitting here today because our ancestors' brains were concerned with just one thing. Well, two things. Reproducing, number one, and then just surviving, number two. I mean, we talked last episode about the selfish brain. The brain's like 2% of your body, and it uses 20% of your glucose on a daily basis, blood sugar
Right.
from carbs. And it does not care about anything else. Whatever's going on, doesn't care. It only cares that it survives, and it will
Yeah.
do, like in Andrea's case, it didn't care. It said, you weigh 90 pounds. I'm afraid that we're not going to have enough food, so let's store it away.
Let's store it away on her tush.
And it kind of achieves that through this whole system in the brain. It's called the melanocortin pathway, which is a series of neurotransmitter and hormone actions that result in our, quote, set point weight and our appetite influencers and things like that, and our metabolic energy expenditure influencers. And so that's all determined through this brain pathway for most people. There are other factors, but this is like a dominant pathway. And so these GLP-1 mimetic medications help to restore that balance in the brain so that the brain can perceive some level of security, even about our food intake. So even though in your case, Andrea, your leptin was so low, so that was giving the brain insecurity about your body weight. That's one of the signals that our brain uses to keep that metabolic pathway strong. So you had a weakness there. But when it comes to the GLP-1 signals, most people with high body weight, it's been found that their GLP-1 signaling is also affected negatively, where either it's not responding in a normal way when you eat, so the hormone itself may not increase the way it's supposed to when we eat. There may be a blunted response, or the brain doesn't perceive it accurately. So there are more hormone imbalances than just leptin when somebody is dealing with these high weight conditions. And so we don't have all these different hormones that we can give people as medicine to restore that balance, but we have some of them available as medication.
So let's get back to the question, which GLP-1 drug is best for me? There are a couple of different classes of GLP-1s. Before we get into that, though, Dr. Cooper, can you give us a little brief history? We all sort of think these are new drugs because they're just suddenly on the scene and they're just pervasive in media right now. But there's quite a history to this. Can you take us back and tell us how these GLP-1s were developed and when they really first came onto the scene?
Yes. I was right there on the scene the day the first one came out, which was Byetta. The brand name was Byetta, exenatide. And it was just groundbreaking because it was the first ever to come out on the scene. And that was almost 20 years ago now. But the original studies were done in the 1980s. So it goes back as far as the 1980s when the scientists saw the potential effect of using GLP-1 medication for obesity and diabetes. Those studies began, I think, in the 1980s, if I remember correctly. And part of the delay in getting these to market was the inability to figure out how to get it beyond an injection method of delivery, because scientists felt that patients wouldn't accept it that much if it was in an injection form. So they kept trying to get it into an oral form, and that really delayed the development of and availability of the medication, because if you're going to do clinical trials, it has to be on the form of the medication that's really going to be the one that hits the marketplace. So they kept trying and trying to make this into an oral medication, finally gave up on that and focused more on the injectable. And the very first one that came out in 2005 was this exenatide short acting form. So you had to dose it. It was recommended twice a day, but people were dosing it 2 to 3 times a day, right before eating, about a half hour before eating. And so it was pretty inconvenient because that's a lot of injections to have to do. But it still was groundbreaking because it showed a huge benefit for people with diabetes. And one of the benefits that they saw early on had to do with body weight as well. And so people with high body weight were also responding to this. And there were even studies done with children using it for weight related conditions and looking at that and seeing some effect of this short acting GLP-1 even in pediatrics. And so these were way back, that was way back almost 20 years ago. And so then shortly after that, about 15 years ago, another form of GLP-1 came out under the name Victoza, which is liraglutide. And that one was a once a day injection. So that was a huge breakthrough at the time, that we got away from having to dose so many times per day. And now we could do a once a day form. And so that really was a great medicine. When it first came out, everyone was quite excited about being able to shift to that once a day. And again, these were recommended at the time for diabetes, but these other benefits were also being seen, because then shortly after the Victoza came out, they actually saw the reduction in cardiovascular risk with taking it. And so reduction in these what are called major adverse cardiovascular events, that was seen years and years ago. So about 7 years ago with Victoza.
That's so funny because they only started mentioning it in like pedestrian media like last year.
Right.
You only heard about the heart stuff. And if you're saying that was noticed 7 years ago, so it took a really long time to sort of get to mainstream media.
It really did. And then people started saying, well, look, we have enough evidence to see that these are safe medications, even for people without diabetes who are having some of these other risks, the cardiovascular risk, the obesity, and metabolic syndrome. A lot of those studies were being run, not necessarily clinical trials, but a lot of research was being published on that. And then eventually the clinical trials came through, and then we got the rebranding of the Victoza as Saxenda, which is the exact same drug as Victoza, a once a day, but now marketed as a weight related treatment. And they noticed that the dose range for weight related worked better at a higher dose. And so that was rebranded and put out in a higher dose range than it was for diabetes. And then shortly after that, then we got Ozempic, which was another breakthrough because that was a once a week semaglutide. So it's another GLP-1 in the same family, but now the breakthroughs have been in the delivery systems. So going from multiple times a day injections to daily to weekly, and then the indications expanding to weight related without diabetes. And so Ozempic then was rebranded and came out under the name Wegovy, same exact drug, but now marketed as a weight medicine at a higher dose than Ozempic, which is the form of it that they market for diabetes. All of this has been a kind of a recurring pattern that we're seeing. And then shortly after that, finally, Novo Nordisk, the company that makes Ozempic and Wegovy, did have a breakthrough for an oral pill form of semaglutide, and that is called Rybelsus. But they're all the same.
That's the one that has the people dancing and singing on TV right now, right?
Wegovy. So
and Rybelsus too.
Oh, Rybelsus too.
Yeah.
But wait, so Wegovy is a higher dose than Ozempic?
Well, it can be the same dose, but the dose range, the top of the dose range is higher than the Ozempic top of the range.
Dr. Cooper, what you're saying is the effect that these drugs have on our body has sort of stayed the same, but the change in drug has allowed it to be injected less frequently. Is that a true statement?
Yes, that's true, but they're not exactly identical. They're in the same family, and they don't work the same way in each individual. The clinical trials will say the semaglutide is more effective than the liraglutide, but in real life, clinical medicine, that's not really necessarily true. Same thing, the exenatide, which unfortunately we can't really get it anymore. It went off patent and there was not a manufacturer. But exenatide also had come out in a long-acting form before the Victoza came out, I believe, in the weekly form, or right around the same time. And it was very effective, and that's not available. And so that was one of the first ones. And so I think it depends on the person, which one of these is going to be the most effective. And there's also different circumstances where a daily versus a weekly is more beneficial. So you have to kind of look at that. So in some ways, the effectiveness of them in their clinical trials are trying to say they are more effective than the one in the generation before. But that's not always true in clinical medicine. It just doesn't play out that way outside of these clinical trials all the time.
So at risk of oversimplifying, which
we always like to do.
I tend to
do.
Well,
we all like to do
every
that.
episode, I tend to oversimplify because that's how my brain works. Okay, so Victoza and Saxenda are essentially the same drug. Ozempic and Wegovy, essentially the same drug. When we go to our doctor, Dr. Cooper, and we're either interested in weight loss or treatment of metabolic syndrome, how do we know which one of these is the best for us? Because I feel like some of these, when it comes to weight loss, they're just sort of prescribed as if every patient is the same.
Right. You forgot Manjaro.
Yeah, Manjaro too. Yeah.
Yeah.
And where does Manjaro fit in all this?
Well, Manjaro, one reason we didn't mention it in this first batch is because it's in a group of its own. So it still does have GLP-1 properties, but it's the first one that's considered what's called a dual agonist. So it mimics not only our GLP-1, but also another hormone called GIP, which is another GI tract hormone that we produce that has the similar effect on our metabolic system. But the ratio of the GIP action versus the GLP action in the Manjaro, which is also branded as Zepbound, that is only like a 1:5 GLP-1 to GIP. So it's a lot less GLP-1 and quite a lot of GIP. So it's considered what's called a dual agonist. So it's not two different medicines in one. It's one molecule that actually mimics both of those two hormones simultaneously. And that's called tirzepatide. And so it's available as Mounjaro, marketed for diabetes, and then Zepbound, marketed as a weight-related medicine. And so that's the newest one, and that's been another breakthrough. So I'd say that's the most recent breakthrough. We've had these breakthroughs with duration of action, and then with being able to get the semaglutide into a pill form was a breakthrough. And now the dual agonist coming out is another breakthrough. But which one is the best for someone? There's so many variables that go into that it is very individual. And it's true that I think the way that our medical system right now is approaching it is more of a cookbook approach, what we call cookbook approach in medicine, which is not really the best type of medicine. It's where you just do the same thing repeatedly for people with a very surface level symptom complex. And that doesn't always pan out, but it's better to do something than nothing, obviously. So it's better to offer something to people. But I think a lot of it, unfortunately, is going to depend on access too. Access to the medication, because you may think that one medication may be the best one for that patient, but you may have difficulty obtaining that for that patient due to insurance barriers or financial barriers or supply. And so the creativity is needed to be flexible and try to find something that will help. These days, we do plan A, plan B, plan C, basically, because there are so many hurdles that we've got to go through. There are some benefits to being on a daily one, believe it or not, versus a weekly. And the only daily one that's available is the Victoza or the Saxenda. Where would that be a benefit? Well, the longer acting they are, the longer they stay in your system, and the longer it takes for them to have their action, basically, to build up an action. So if you want something that's shorter acting and quicker acting, then you go for the daily. And in some cases, we do that with some patients who say they may be wanting to become pregnant or conceive within a certain time frame. So we'll have to be able to take that medicine out and get it out of their system quicker. We want something with a shorter half-life. So that would be a daily medicine, for example. Or if somebody has a lot of side effects, you don't want them to have to suffer. Even though they stop the medicine, it's now taking weeks for it to get out of their system. So if they're prone to that, the daily might be better. And some forms of these medicines are easier to titrate the doses up from a very low dose to a therapeutic dose so that you can avoid side effects, where others that are in fixed quantities that you have to inject each week, they don't offer that ability to adjust the dose as easily, and the dose increases are big jumps, and that may not be right for everyone. So there's so many different things that go into it. And we forgot to mention one of the GLP-1s. I can't believe we forgot to mention it, but it's marketed as Trulicity. And that one has not, yeah, that's marketed for diabetes. And the same company, Eli Lilly, that makes the Manjaro makes the Trulicity. And I think instead of going the avenue of the dual diagnosis for Trulicity, marketing it, for diabetes and then obesity, they decided instead to just jump to the Manjaro from that. But that's also a good medication that's out there.
I think that's the one that my insurance company decided not to cover. And I think that's why we had to go to a different one. But I'm glad that you said that, Dr. Cooper, because there's the efficacy of these drugs, meaning which drug is actually best for your body. But when you start to figure in side effects, when you start to figure in insurance coverage, all that stuff plays in. And it's nice that there are a number of options so that if you can't tolerate this one very well, let's try this one. Or if your insurance denied that one, then let's try this one. That's a really important point that we should make.
And everybody has different side effects too.
Yeah. Which one are you on, Andrea?
I take Manjaro now, but I have literally been on every single one of the drugs that Dr. Cooper mentioned.
And do you have any side effects?
Yes, I do have side effects, but I feel that for me, it is worth it. And it's very strange. The side effects come and go. And seriously, I have been on these drugs for 15 years or whatever.
Mm-hmm.
And I've had side effects with all of them. And I am here to say that they have all pretty much worked, even though I've had side effects, and I'm willing to tolerate any of the side effects because I feel that they've changed my life. I also work with other drugs in conjunction with these drugs, but the efficacy, as they say, of the drugs are life-changing. And sometimes I have some nausea. I might throw up if I sort of eat too much, maybe, or too fast. And some of that is because I've also had a gastric sleeve, so my stomach is small. And I sometimes get ahead of myself because with these drugs, the way that the food is absorbed, it's like it goes down slower. And so you have to make sure that you didn't go over the line. And you just have to be careful. But for me, that danger zone, as we call it, is it's okay. You weigh out the pluses and the minuses. And as with anything in life that's fantastic, you have to weigh out the pluses and the minuses.
When I first came to Dr. Cooper, I think you put me on Victoza in the beginning. I was pre-diabetic, high blood pressure, high blood sugar, high cholesterol. Everything was going in the wrong direction. My family doc didn't know what to do. And slowly but surely over time, things reversed. And I take Ozempic now. And for those of you who've never taken one of these drugs, they come generally in a pen, which is like the size of maybe a Sharpie, a fat Sharpie. And it has a microneedle on one end, and then it has a dial on the other end. And you just basically dial up the dose, put some alcohol on a little swab, and I do it on my stomach on either side, and just inject it in there. You can't even really feel the needle go in. It's so tiny. And I do that once a week. And like you, Andrea, I think what these drugs have done for me, it's really balanced out the tempo of my appetite and my metabolism. So I don't feel super hungry ever. And it's easier to feel full. If we go out for a meal, I'll only can usually eat about half of the entree and then have the rest boxed up and brought home. But what I do try to do is that these drugs generally make you not feel as hungry all the time. So if you don't pay attention, you can literally go 7, 8 hours and not feel hungry, but you really do pay a price. And so I've really got that systemic eating dialed in, Dr. Cooper. Every few hours I'm eating whether I feel super hungry or not. And that really has led to just a nice cadence, a nice balance of fueling. And so my brain is settling down. My body weight is 40 pounds less than when I first saw you 10, 11 years ago. So I feel like there's a real balance, but that balance only takes place after these labs that we do every 3, 4 months just to see how everything is working in conjunction with one another.
I think for me also, I eat all day long. I eat small meals all day long, healthy foods. But the biggest miracle for me is that the weight hasn't come back.
Yeah.
For 50 years before this, I would lose the weight. I would lose 100 pounds, 50 pounds, 75 pounds. And it always came back. It was always that dreaded time when it would come back. And the weight hasn't come back. And, it's like 160 pounds is gone. And I feel like it's gone. It's gone. Bye bye.
Yeah.
And that's the biggest thing, obviously big, that is goodbye. And it just makes it so that I can live my life and I don't have that worry. And that literally was an anxiety every day.
Not to mention the fact that if you and I had not seen Dr. Cooper, at some point it would have led to a catastrophic outcome.
Oh,
whether
for
it's
sure.
a stroke or a heart attack or whatever, that it
was all happening. I mean, it was all leading up to it. There was going to be some kind of volcano happening in there.
Dr. Cooper, I'm thinking there are two sort of classes of patients who might consider the GLP-1. One is that person with metabolic syndrome, which you're very good at understanding and treating. The other person is that person who just has excess weight. How do we know when it's time to get on one of these drugs? Obviously, if we're in the metabolic syndrome class, we know that's an obvious answer. But for those folks with just excess weight, with no metabolic, real serious issues, how do we know?
Well, I think that some people, and a lot of this we've talked about before, is based on genetics. So some people will come in and their weight, like you, Mark, your weight wasn't really that elevated at all, but it was just more that you had that full-blown metabolic syndrome. And so your category of people that are not in that real high weight category tend to have a little bit more long-term dependence on medication to straighten stuff out, which is weird. You wouldn't think that. But when you have the really elevated weight and metabolic syndrome, a lot of times we get to some point where we can really be tapering these medicines as the weight is coming down and normalizing and all those health parameters are. But again, people that are more in that normal-ish weight range or overweight, but not really in a very high weight range, that group tend to be more difficult and to taper medication. And you kind of become more needy of these meds to keep the health risks away, basically. But just a point to make there. And I think that if people have extra body weight and they've looked at their whole panel of labs and they determine that they have absolutely no increased cardiovascular risk at all, like good blood pressure, no plaque in their arteries, no risk of plaque in the arteries, no prediabetes, no insulin resistance, no kidney disease, no liver disease, everything's great. And they feel great. If they feel great, they have lots of energy, but they just have this weight that they're carrying around. That's still a metabolic issue because the weight, why are they carrying that around? So we may find things like low leptin levels or high famine signals or something that is linked to a person that would carry that extra weight, but it's not affecting their health. So then that's a really important personal decision for someone to make, what they want to do. And we totally support patients, whatever their decision is on that. Because even if they are completely healthy, they have no mobility issues, but they still are disturbed by having to carry that extra weight around. And we can see that there's this imbalance in the blood that's triggering that. Then they could approach a pharmacologic treatment. And that's really their personal decision if they want to do that. And same thing, it's their personal decision if they don't. But then if we have patients that, even if they don't have a lot of extra weight at all or any extra weight, and they still have all this metabolic dysfunction that's putting them in that high risk for heart disease, strokes, diabetes, fatty liver, that's a person we would really urge to get treated and to use the pharmacology to help treat them. And it's not about them losing 10, 20, 30, 40 pounds. It's more about that risk that they're having. And so everything is looked at through those lenses. And so if you've got somebody that their only issue is mobility or energy levels because their metabolism is sluggish, so they have low energy, but they're healthy otherwise, well, they also deserve to take advantage of some of these medications that can help restore the balance of their metabolic system so that they don't have to be in that situation, so that they may be able to improve energy levels and reduce that burden that's creating mobility issues. So I see it as a real personal decision. And sometimes I guess the patients that I push back on the most are the ones that don't want to do any pharmacology, very much against it. And yet they have a lot of these disease risks, like real red flags. And my focus is always preventive medicine. So I'm always thinking, well, this could reduce your cardiovascular risk. This could reduce your kidney disease. This could do so much to prevent future dementia or diabetes complications. And so I try to just show the benefits of being treated versus not, but then a lot of them might want to do their own little trial where they try to like dial in their lifestyle even more, even though they've already been doing that, dial it in even more, and then check another set of labs. And we sure enough find out it's not doing enough. If you want to prevent these diseases, should really take another look at the current pharmacology landscape and what could be done to potentially help reduce that risk. But again, it's a very personal decision, but the doctor's position isn't to push people into anything. It's really more to just provide information and to help put that in front of patients and show this is what we see, that as in terms of your risk factors and where you are, and this is what could potentially help, and these are the potential side effects or risks and benefits of that treatment. And then it's really up to the patient to decide whether that seems appropriate or not for them.
It's exciting too, Dr. Cooper, that when the metabolism starts to get corrected in the body, like I don't have to inject testosterone anymore because my body is now producing enough and it's in balance. And it's exciting when that happens. But since a lot of what I have is probably genetic, I had a grandfather with diabetes, I'm probably going to be on some form of medication for the rest of my life, but I'm okay with that because knock on wood, I'm not going to just drop dead of a stroke or a heart attack because we've gotten ahead of this stuff.
I feel the same. I feel like I've sort of put a barrier to a lot of the things that in my family went wrong. And I feel like I put a little stop to it. I feel like I can go through whatever's left of the rest of my life a little bit more healthy. And I want to live the rest of my life as healthy as I can. And then whatever.
I love it.
I
love it.
I just want to be as healthy as I can be. Okay, good.
Okay, Dr. Cooper, I feel like you did a great synopsis at the end there of the value of these GLP-1s. Andrea, any final thoughts as we wrap it up?
I think these drugs are fantastic. I'm a fan. I'm definitely a fan. That's my 2 cents. I'm a fan.
Well, Andrea too, and people know this if they've listened to the podcast over time, but this struggle, it started when you were 8 years old, and the shaming and the frustration and the excess weight that was so hard to deal with on so many levels.
Right. If I had these drugs like when I was 12, the amount of time, energy, and mental energy, as well as physical energy that I would have saved, I really would have a lot of time on my hands right now.
I think what my takeaway is that this really is just a process of education for me. And I just want to encourage people to try to find a great doc who really understands this stuff, and don't listen to the stuff on social media feeds and, oh, now I'm drinking vinegar for breakfast. Yeah, it's like, find a good, reputable scientific source of information, educate yourself, and then pay attention to yourself. A lot of this stuff has to do with just really getting in sync with what your body is feeling and doing. And then pairing that up with a great doc, pairing that up with some medications that make a difference. And it really, really is life-changing. I played pickleball yesterday, for gosh sake. Is that a sign that I'm getting old?
No, it's a fun thing. It's a fun thing.
And I can still walk today. So it's life-changing, this stuff is. Well, this has been fun. I guess the answer to which GLP-1 drug is best for me is it really depends. We talked for a lot of different reasons. But great information again. Dr. Cooper, thank you so much. Andrea, for another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.
I'm Mark Wright. Thanks for listening to Fat Science with Dr. Emily Cooper. New episodes drop every Monday. If you've enjoyed the conversation, subscribe, rate, and review this podcast. This production is for informational purposes only and is not intended to replace professional medical advice. Join us next week for another episode dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better.